Morning. My name is Dr. Neal Weinreb. I'm a voluntary associate professor at the University of Miami Miller School of Medicine. I'm in the Department of Human Genetics and also in the Department of Medicine, Division of Hematology. Today, we're going to discuss some of the recent reports at the World Lysosomal Disease Storage Network meeting related to Gaucher disease. Gaucher disease is, of course, a lysosomal storage disorder, one of approximately 50 to 60 in that category. Its hereditary pattern is that of an autosomal recessive disease. Turn to the WORLDSymposium. This is an international meeting which is held annually in February and covers areas of basic research, translational research, and clinical research associated with all of the lysosomal storage diseases. And this meeting is a focus for all researchers and clinical investigators and clinicians with an interest in lysosomal disorders. Attention at the meeting was following Gaucher disease with biomarkers. Traditionally, we use certain enzymes which are secreted by macrophages in large amounts for following patients with Gaucher disease. Some of these markers are useful to some extent in trying to assess severity of the disease, although the correlations are not that good. The markers are also useful for following response to therapy, but they're not particularly useful, as we've had them to date, for predicting or determining who should actually be started on treatment. A lot of attention is now being focused on that minor substrate that does build up in Gaucher disease, glucosylsphingosine, or lyso-Gb1 or lyso-GL1. This is a study also from Israel, but with participants from some of the German centers, and has been replicated in some of the UK centers. I'm referring to the two bar graph figures. Middle one shows response in patients who had been on treatment and who still had, despite enzyme replacement therapy, elevated levels of glucosylceramide. The normal level, I should point out, is about up to 7.5, and you'll see that even with the enzyme replacement treatments, these individuals still had elevated levels of 50 or higher. Curiously, with further follow-up, there was some decrease. But I think what's more impressive are the patients who had never been treated prior to having their first determination, and these are the ones on the far left of the slide. And you can see that untreated patients have, generally speaking, on average, markedly elevated levels. And after even several months of treatment with enzyme replacement therapy, there does seem to be a decrease. Glucosylsphingosine testing can be done on whole blood specimens submitted for testing of plasma, but it can also be tested using dried blood spots, which makes it a useful test both for monitoring patients where blood specimens are not easily obtained and transported to a central laboratory, but also it can be used as a diagnostic test for Gaucher disease, either as a standalone or to supplement the classic beta-glucosidase enzyme assay, which represents the gold standard. So I'm going to now turn to, for the remainder of the talk, to issues related to treatment. One of the newer developments in treatment has been the emergence of an oral substrate reduction therapy treatment called eliglustat. This drug was approved in the United States after extensive clinical trials in 2014. There have been many studies presented, including a year ago, of the use of this drug for switch treatment, but I'm going to concentrate on a smaller study called the ENGAGE study, which there was investigation of the use of eliglustat in patients who were treatment naive. This was originally a placebo-controlled study, but then all patients transitioned over to an open label, and this report by Dr. Pram Mistry, representing the ENGAGE study group at the World Meeting, gave results from 4.5 years of follow-up. The summary, which is shown in the chart, shows that patients who had fairly severely enlarged spleens on average at baseline had a very impressive response with the mean spleen volumes decreasing from about 17 to 5 times the normal predicted size. Similarly, patients who had enlarged livers, about 1.5 times normal on average, achieved on average normal liver volumes at the end of the study. Thrombocytopenic patients, by and large, improved, and patients were not particularly anemic in this group at the start. The hemoglobin did increase a little bit. And perhaps in what is one of the more unique aspects of this study, patients who were osteopenic at the start of study, by and large, showed improvement. But I want to show you some of the more detailed slides here, because I think it's important to note and get a sense for the overall likelihood of success. And I think you'll notice that in this slide, which shows the improvement in platelet counts, most patients actually achieved normal platelet counts, which is shown by the dotted line. But you'll notice that there are a small number of individuals who did not apparently achieve normal levels or even necessarily achieve the treatment goal of a platelet count of 120,000. And the lesson to be derived from this is that there will probably be some patients who may not respond as predicted, but it may be necessary to look at such patients in terms of whether they are actually treatment compliant. In the case of this study, we knew that they were, or whether their metabolizer status is not that which was predicted by the testing done, and they may actually therefore prove to be more rapid metabolizers of the drug than would be otherwise predicted. You'll note the same division in patients with regards to liver improvement. Most patients actually did achieve normal liver volumes, but again, a few remained with some residual enlargement of the liver, especially those in whom massive hepatomegaly was present before starting treatment. The assumption being there is that there may already be some fixed fibrosis, which limits the response and again highlights the need to start treatment before irreversible disease occurs. It's important to use these various follow-up measures to do a comprehensive evaluation of patients' response so that you can determine who is having suboptimal response to therapy and, if necessary, make adjustments. And this will, of course, become more relevant as new treatment options become available. I'm not going to spend a lot of time on this slide, but the emphasis here is that eliglustat therapy, as I mentioned, is not a simple treatment. In some respects, despite being invasive, enzyme replacement therapy is easier to administer because it's infused intravenously. We usually don't have issues related to compliance, since we know the patients who are not showing up at the clinic to get their treatments, and we don't have the drug interactions. There are significant drug interactions with commonly used drugs such as antidepressants and antihypertensive medications, antibiotics, which may necessitate either adjusting doses of eliglustat or sometimes even discontinuing the drug in order to avoid potential toxicity. So to keep track of this somewhat complicated monitoring that's necessary, it's highly advisable to have a good specialty team featuring particularly specialty nurses who can work very closely with the patients to document their medications, to provide guidance about potential side effects of the medication, and to just be sure that patients are receiving optimal care. Now that, of course, is certainly true as well for patients on enzyme therapy, but again, it's useful again to try to treat patients with these type of specialty teams. Now, even though enzyme treatment has been available for nearly 30 years at the present time, and studies have shown that patient compliance has actually turned out to be remarkably good, there has been some interest in seeing if one can decrease the actual burden that patients undergo in receiving enzyme replacement therapy by shortening the duration of the infusions. Now, in reality, one of the major steps to helping patients on enzyme treatment was when it was found that it could be administered safely in a home setting. And in fact, outside of the United States, there are even some patients who do self-administration. But traditionally, enzyme treatment has required anywhere from 1 to 2 hours for the infusion. And of course, if somebody's getting it at the clinic, then there's travel time as well as registration time involved, which can mean that a patient may end up losing anywhere from a half to a full day of work. So any step to make the infusion shorter theoretically should be well received by patients. And this study, which was done again at the Shaarei Tzedek Hospital in Israel, you may wonder why I quote this site so frequently, but that's because they do have such a large number of patients with type 1 Gaucher disease, somewhere about in the vicinity of 800 patients at any one given time. So they clearly have a very good population for study. In this particular study, however, the 15 patients who had not previously been on enzyme replacement treatment were treated with veloclucerase in a stepwise reduction fashion. And the bottom line, which you see in the graphs, was that the 10-minute infusions were well tolerated. There were no significant infusion reactions. Most infusion reactions that take place with enzyme therapy are caused by infusing a large dose excessively rapidly, but this did not appear to occur with this stepwise reduction approach, so that this group is now suggesting that 10-minute infusions with veloclucerase are appropriate to try in patients who don't have a previous history of significant infusion reactions. I mentioned that there is a lot of interest right now in new treatments for Gaucher disease. And one drug which has received a lot of attention is a drug called Ambroxol, otherwise known as Mucosolvan. This drug is actually a cough suppressant, very similar in some respects to Mucomyst. Unfortunately, this mucolytic agent is not available in the United States. It was never licensed many, many years ago by the FDA, and because there's no patent protection, there really has been no real motivation for the manufacturers to try to go through the expense of an FDA trial. So it is currently not available in the United States, but it is available throughout much of the rest of the world. Dr. Ari Zimran presented a compilation of results in patients who have not been treated in the context of a formal trial, and some of these results are, to say the least, intriguing. He cited results from Dr. Narita in Japan, who treated 5 patients with type 3 disease and found that they responded not only systemically, but also in terms of improvement or stabilization of their neurological disease. Dr. Zimmer has treated other patients in Israel and has now put together what is essentially a registry of patients treated with Ambroxol, and he reported these results at the meeting, indicating that serious adverse events were very uncommon. A number of patients have discontinued the medication, some for personal reasons, a few because the dose is usually larger than that necessary for use of the drug as a mucolytic agent, and therefore expense became an issue in some third world countries where patients were being treated. But of the patients that he treated, it was of some note that patients also with type 1 disease showed improvement in platelet count and some reduction in glucosylsphingosine biomarker levels. The hope is that patients, if not actually entered on a formal study, will continue to access Ambroxol when they're not doing well on other already approved treatments, and by putting together information, it may be possible at least to promote a strong case for using Ambroxol in certain countries where patients have diseases for which, disease variants for which there's no other treatment. Now, in a more conventional sense, another substrate reduction therapy, which, again, briefly, I didn't mention what substrate reduction therapy is, but in one sentence, substrate reduction therapy are drugs which retard the biosynthesis of glucocerebroside, by inhibiting glucosylceramide synthase. So one such drug, which is currently in a trial for patients with type 3 Gaucher disease, is called venglustat. You can see this is so far a very limited study in terms of the number. 6 patients are currently evaluated at this first juncture point of 6 months. So far, it's been gratifying that there have been no really severe toxicities associated with this medication. Most of the side effects have been mild, and in fact, most of the actual adverse events have been related to the lumbar punctures, which are performed as part of the study in order to assess both CSF levels of the drug as well as CSF levels of the biomarker glucosylsphingosine. Now, in terms of the efficacy endpoints, and you'll notice that on the right side of this slide are the results for the plasma levels of both glucosylceramide as well as glucosylsphingosine. And both substrates in 4 of 5 patients did decrease rather dramatically with the venglustat therapy along with the continued enzyme therapy. And you'll notice, of note, is that after the venglustat was started, elevated levels, despite enzyme therapy, continued to decrease, although not quite to the normal levels. On the right side, we have the report in the cerebrospinal fluid. Again, 4 patients out of the 5 had rather dramatic responses. In these patients, we would not have anticipated any decrease just with enzyme therapy, but there was decreased therapy in the patients with venglustat. I spoke with Dr. Schiffman after his presentation, and he concedes that despite extensive efforts to understand the one patient who has failed to respond, there still is no cogent explanation at this particular point. So clearly it's going to be important to get more information on these patients with regards to larger number of patients in the trial. And for the last 2 slides, I'm going to turn to what is now the new kid on the block, so to speak, and the area of increasing fascination, namely the possibility of gene modification or gene correction therapy for lysosomal storage diseases. There were a large number of papers presented on this subject for a variety of diseases. I'm going to show you some of the early evidence presented for a gene correction therapy using lentiviral transduction and use of hematopoietic stem cell infusion for correction of Fabry disease. The reason I'm using Fabry disease is because the evidence is greater. The Gaucher trial is just opening at this time, and there's only 1 patient so far enrolled. The essential design of this type of treatment is that one obtains hematopoietic CD34 positive stem cells from a patient and then exposes these cells to the lentiviral vector, the lentivirus having been corrected by insertion of a normal GBA1 gene. These cells are then subsequently isolated and concentrated and validated. Once the cells are actually obtained, the patient then undergoes a bone marrow conditioning and myeloablation with a busulfan regimen, following which the stem cells are infused into the patient, where they engraft after a period of expected pancytopenia, sometimes associated with some mucositis. As with most of these trials, obviously the safety issues are the primary endpoints to be looked at. And in the Fabry trial, where approximately 5 patients have been treated so far, no unexpected safety issues or trends actually emerged. Turning to efficacy, the gold standard is looking at actual inclusions within the kidney and within other cells and seeing if they reduce in number after treatment, in this case with the therapy, the lentiviral therapy. And you can see in this slide, on the right side of the slide is the baseline in blue for the number of kidney cell inclusion bodies noted prior to the initiation of treatment, and in the red, the marked reduction that took place in this patient with kidney biopsy after being on the trial for approximately a year. Other studies that I'm not showing show that the actual viral vector number after an initial drop-off does persist, suggesting that the engraftment persists for a long time, which is a proof in concept for what would turn out to be one of the major advantages of this type of gene therapy, namely that it may be possible to get one treatment which will last you for your entire life. I'd like to conclude with a different type of gene correction therapy, which is also being used in other disease models, particularly and prominently for treatment of hemophilia. And this is using as a viral vector for carrying the corrected gene, the adeno-associated virus 9. And this has been studied extensively. It has a very well recognized safety pattern. This is a study for patients with type 3 Gaucher disease, and the medication, namely the viral vector, is actually injected through intracisternal injection directly into the CNS. This trial is in a non-human primate model. I'm discussing here, however, not the trial with Gaucher disease, but because that, again, is not yet in progress, but as a proof of concept, a trial of this approach in another neurodegenerative disease, which is called protemporal dementia, and which is also a irreversible, so far untreatable disease. The disease is caused by deficiency within the brain of a molecule called progranulin. The purpose of the gene correction therapy is to insert a normal progranulin gene into the cells, into the viral vector, which is then directly injected into the brain and then transfects neurons and carries with it the corrected gene, with the result of secretion of progranulin molecules and hopeful correction of the disease. So in summary, Gaucher disease is one of a large number of lysosomal storage diseases. The best care for patients with Gaucher disease is frankly administered at Gaucher treatment centers, if not necessarily all the time, but at least as a resource to help follow patients along with their primary supporting physicians. There are all sorts of strange comorbidities associated with Gaucher disease beyond the classic manifestations, ranging from potential malignancies such as myeloma, Parkinson's disease, and other neurological deteriorations, as well as the strange variants that I mentioned, and of course the untreated need, the unmet need for treating patients with neuronopathic disease. So there are other unmet needs as well, including incomplete skeletal responses, prevention of Gaucher disease-associated malignancies, such as myeloma, B-cell lymphoma, liver cancer, renal cancer, melanoma. Also, prevention of Parkinson's disease in both Gaucher disease sufferers as well as their relatives. And finally, treatment for neuronopathic Gaucher disease. And lastly, I think it's imperative that we mention that there are also important socioeconomic issues related to neonatal screening of Gaucher disease and other lysosomal storage disorders, development of cost-effective treatments, and worldwide dissemination of diagnostic and therapeutic advances also needs to be effectively addressed.